After studying this module on schizophrenia, you should be able to know the symptoms of schizophrenia and its subtypes, understand the epidemiology of schizophrenia, develop an understanding of various causes of schizophrenia, and know the types of the treatment modalities available for schizophrenia. For all the psychological disorders, schizophrenia is one of the most severe psychopathology. Schizophrenia was first carefully described by Kraepelin in 1896. He used the term dementia praecox to refer to a group of symptoms which is now known as schizophrenia. The term schizophrenia was introduced by the Swiss psychiatrist Eugen Bleuler in 1911. Schizophrenia is derived from two words in German, word Schizen, which means to split, and the Greek root phren, meaning mind. This derivation gives a sense of split mind. Bleuler identified that certain psychological functions such as language, thoughts, and emotions, which are normally integrated, are split or disintegrated in schizophrenia. Exact nature of schizophrenia remains disputed. However, the consensus is on the view that it comprises a number of disorders characterized by distortions of thinking and perception. Schizophrenia includes severe disturbances in thinking, speech, perception, emotion, and behavior. It involves loss of contact with reality, bizarre behavior, and distorted expressions. Now we must know the clinical picture of schizophrenia, which includes symptoms and signs of schizophrenia. There are two major diagnostic systems to provide criteria to diagnose schizophrenia, the ICD and DSM. DSM is very comprehensive and popular among psychotherapists at diagnosis of schizophrenia. DSM-4-TR states that two or more of the given symptoms should be present for a significant period of time during 1 month period, which are delusions, hallucinations, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. Only one symptom is required if the delusions are bizarre or the hallucinations consist of voice keeping up a running commentary on the person's behavior or thoughts, or involve two or more voices conversing with each other. Dysfunctions are found in various areas of life settings, especially in work, interpersonal relations, or self-care. Sign of disturbance prevail for at least 6 months, but at least 1 month of symptoms from the list of delusion, hallucination, disorganized speech, grossly disorganized or catatonic behavior, and negative symptoms. Another way to diagnose schizophrenia is to examine which symptoms cluster together and to examine underlying mechanisms contributing these symptoms. Factor analysis of the signs and symptoms of the various subtypes of schizophrenia has identified 3 clusters of symptoms: disorganized positive and negative symptoms. The disorganized cluster is featured by disorganized speech, behavior, and inappropriate or flat mood. The positive clusters incorporate hallucinations and delusions, whereas negative symptoms are characterized by the behavioral deficits like apathy, lack in motivation, or poverty of speech. Detailed explanation about the symptoms of schizophrenia. Positive symptoms. These are those that reflect an excess or distortion in normal behavior and experience such as delusions and hallucinations. In contrast, negative symptoms reflect an absence or deficit of behaviors that are normally present. Delusion. A delusion is a false belief about reality firmly held in spite of strong disconfirming evidence. It involves disturbance in the content of thought. Delusions are common in schizophrenia, occurring in more than 90% of cases at some point of time in their illness. In schizophrenia, certain types of delusions are quite prevalent. Persons suffering from schizophrenia may have belief that their thoughts, feelings, or actions are being controlled by some external agency. Delusion of reference is also common among schizophrenics, where some neutral environment event is believed to have personal meaning intended only for the person suffering from schizophrenia. Hallucination. A hallucination is a false sensory experience that occurs in the absence of any real stimuli or event. Person affected by schizophrenia may see the objects or hear the voices that in real have no existence. Hallucination can occur in different sensory forms: auditory, visual, olfactory, tactile, gustatory, etc. But auditory hallucinations are more common, being present in up to 74% of the cases with schizophrenia. Visual hallucinations occur less frequently, present in only 15% of cases, and tactile hallucinations are rare. Patients can become emotionally involved in their emotions. In some cases, they may act on their hallucinations and do what the voices command them to do. Negative symptoms. These are basically behavioral deficits. Important negative symptoms in schizophrenia include lack in energy and interest level, that is called avolition; poverty of speech, in which the amount of speech is adequate but vague and repetitive, which is called alogia; and lessening experience of pleasure, called anhedonia. Researchers found that schizophrenic report less pleasure on questionnaire about hypothetical situations, about food, recreation, sex, etc. But with actual situations like film, they report equal like without schizophrenic. Flight affect and asociality are also part of negative symptoms. Flight affects are characterized by no emotional experience on stimulus, stare vacantly, face muscles flaccid, eyes lifeless, toneless voice. Flight affects are found in 66% of schizophrenic patients. Schizophrenic patients are severely impaired in their social relationships. Disorganized symptoms. Disorganized symptoms of schizophrenia are characterized by disorganized speech and disorganized behavior. Person affected with schizophrenia express problems in organizing ideas and speaking so that a listener may fail to understand. Their speech may be disordered by loose associations. In some cases, patients speak completely new words known as neologism. Basically, an affected person fails to make sense. The failure is attributable to the negative slippage, derailment, or loosening of associations, or in its most extreme form, as incoherence. Affected persons with schizophrenia have gross impairment in their routine daily life in different areas of functioning, such as self-care, social relations, and work setting. Schizophrenic patients may be seen wearing unusual dresses, like wearing an overcoat and gloves on hot summer day. They may disregard their personal safety and hygiene. Now we know about subtypes of schizophrenia. Schizophrenia is a very heterogeneous kind of psychotic disorder which encompasses a variety of disorder processes having different causes and effects. It makes diagnosis of schizophrenia very complicated. In DSM-4TR, there is recognition of many types of schizophrenia, in which 3 major and 2 additional types of schizophrenia have been categorized. 1. Disorganized type. This type of schizophrenia usually occurs at an earlier age. It is manifested by disorganized speech, disorganized behavior, flat or inappropriate affect, and no evidence of catatonic schizophrenia. As the disorder progresses, the person shows infantile behavior. A silly smile and inappropriate laughter are more common symptoms. Speech becomes tough to understand and include baby talk, childish giggling. Patients may have severe disruptions in their self-care abilities and inability to perform routine tasks. The prognosis of disorganized schizophrenia is generally poor. Treatment of disorganized schizophrenia is least effective and has a likelihood of modest gains. 2. Catatonic type. According to DSM-4TR, in catatonic schizophrenia, the clinical picture is dominated by at least 2 of the following features: immobile body or stupor, excessive motor activity that is purposeless and unrelated to outside stimuli, extreme negativism or mutism, assumption of bizarre postures or stereotyped movements or mannerisms, echolalia, which basically means mimicking the other's phrases, or echopraxia, which includes imitating actions of others. Patients in a catatonic stupor resist any effort to change their position. They may suddenly get excited from the state of stupor. During this phase, they may become violent, shout excitedly, or may openly indulge in sexual activity, attempt suicide, impulsively attack and try to kill others. Catatonic type of schizophrenia is seldom seen today because medications work effectively. Then we have paranoid schizophrenia. The person affected with paranoid schizophrenia shows suspiciousness and difficulty in interpersonal relationships. They are preoccupied with the delusions or frequent auditory hallucinations. There are found no evidence of marked disorganized speech, disorganized or catatonic behavior. Flat or inappropriate affect in paranoid schizophrenia. Illogical ideas and beliefs are often organized and coherent and are observed but in a delusional framework. Most prominent delusion is persecutory delusion, in which an individual may become highly suspicious of relatives or acquaintances and may complain of being watched, followed, poisoned or talked about by any means. Delusions of grandeur are also common in paranoid schizophrenia. Person with such delusions may, for example, claim to be great leader or scientist or any prominent figure. Then we have schizophrenia undifferentiated type. Symptoms of schizophrenia that do not meet the criteria for the disorganized, catatonic or paranoid type are categorized under undifferentiated type of schizophrenia. Person with this type meets the usual criteria for schizophrenia but does not clearly fit into one of the other types because of mixed symptoms. Then we have residual type of schizophrenia. When the patient no longer meets the full criteria of schizophrenia but still shows some sign of the illness, then one comes under residual type of schizophrenia. This category is applicable for those people who have suffered at least one episode of schizophrenia but do not show any prominent positive symptoms such as hallucinations, delusions or disorganized behavior or speech. Instead, clinical picture contains mostly negative symptoms, although some positive symptoms may be present in milder form. Epidemiology of schizophrenia. Prevalence. About 1% of adults are diagnosed as having some form of schizophrenia according to APA 2000. Prevalence rate appears stable across countries, cultures and over time, with the onset of problems typically beginning between the ages of 20 to 35 years. It is less common among children and adolescents than it is among adults. On average, women develop the condition 3 to 4 years later than men and show a second peak of onset around menopause. The lifetime morbid risk for developing schizophrenia is widely accepted to be around 1%. It means that 1 out of every 100 people born today who survive until at least age of 55 will develop the disorder. Age of onset. The majority of cases of schizophrenia begin in late adolescence and early adulthood. The onset of problems typically begin between the age of 20 and 35 years. On average, women develop the condition 3 to 4 years later than men and show second peak of onset around menopause. Length of episode. It is an episodic disorder with periods of acute problems frequently separated by periods of remission. Richards, Wiesman et al. In 1998 followed a cohort of individuals with schizophrenia for a period of 15 years following their initial episodes. 2/3 of those followed had at least one relapse, and after each relapse, 1 in 6 did not recover. 1 in 10 committed suicide over the course of the study. Sex differences in schizophrenia. The gender difference has been found in every culture in terms of occurrence of schizophrenia. Interestingly, schizophrenia tends to begin earlier in men than in women. An average age of onset of schizophrenia is around 25 years for men and around 29 years for women. Many researchers believe that males develop a more severe form of the disorder than females. Socioeconomic status. Prevalence rate of schizophrenia is profound in low socioeconomic status. Stresses related with low socioeconomic status may cause or contribute to the development of schizophrenia. Socio-cultural factors. People of Afro-Caribbean origin living in the United Kingdom seem to have higher than expected rates of schizophrenia. Rates of schizophrenia also seem to be high in Western Ireland and Croatia, and especially low in Papua New Guinea. The Hutterites, a Christian sect that migrated to the United States from Europe in late 1800s, also show a low prevalence of schizophrenia. Then we have different explanations when it comes to etiology of schizophrenia. First, we have biological perspective, under which we study genetic vulnerability to schizophrenia. A good deal of research supports that schizophrenia has genetic component. Substantial data have been reported from investigations of family history and or genetic variable for schizophrenia. These studies are of four types: family studies, twin concordance, adoption studies, and mode of transmission studies. Family studies. Many studies have revealed that schizophrenia is a familial disorder and runs in families. A study was done by Gottesman in 1991 to search out the genesis of schizophrenia, which is based on compilation from family and twin studies in Europe population between 1920 and 1987. This study shows strong association between the closeness of the blood relations and the risk of developing the disorder. The prevalence of schizophrenia in the first degree relatives, which may include parents, siblings, and offsprings of the proband with schizophrenia, is about 10%. For second degree relatives who share 25% of their genes with the proband, example half siblings, aunts, uncles, nieces, nephews, and grandchildren, the lifetime prevalence of the schizophrenia is close to 3%. A study done by Tunsang in 2000 indicated that the risk for schizophrenia among relatives of an identified case correlated with the degree of shared genes. It showed the strength of genetic linkages in schizophrenia. Rate of concordance was found high in families than general population. Twin studies. Several studies show a high concordance for schizophrenia among identical or monozygotic twins, where they share 100% genes, over people related in another way, including fraternal or dizygotic twins. Studies have reported concordance rates for schizophrenia in monozygotic twins of between 30 and 40% and between dizygotic twins of 10 to 15%, suggesting a part genetically mediated risk for schizophrenia. Adoption studies. The Danish adoption studies traced the biological relatives of 34 adopted children who later developed schizophrenia and those of 34 control cases with clean pedigrees and compared the prevalence of schizophrenia among them. They found only one person diagnosed as having chronic schizophrenia among the relatives of either case or controls. These critics provide no evidence that schizophrenia is inherited. A more recent study of genetics reported by Taineri et al. In 2000 compared rates of schizophrenia in the adopted way offspring of both mothers diagnosed with schizophrenia and those without the diagnosis. Risk for schizophrenia was 4 times greater among the children of the women diagnosed as having schizophrenia than among the children of the comparison mothers, a total comparison of 8.1% versus 2.3%. Schizophrenia has been a matter of debate over the role of nature and nurture in the development of mental health problem. Evidence relating to genetic factor has been closely scrutinized and has not been without controversy. It can be concluded from the studies reported that if genetic factors play a role, then its concordance rate should be 100% in identical twins, but it has not been found so. Wahlberg et al. In 2000 reported an interaction between genetic and environmental factors. Role of biochemical factors in schizophrenia. First, we have dopamine hypothesis. Dopamine is a neurotransmitter which plays major role in schizophrenia. Neurons mediated by dopamine are found in limbic system in a brain area known as A10 with links to the thalamus, hippocampus and frontal cortex. Dopamine hypothesis suggests that the experience of the people diagnosed with schizophrenia result from either an excess of dopamine receptors supersensitivity to normal amount of dopamine. Evidence of increased dopamine activity comes from a number of studies. Amphetamine use increases dopamine levels and can produce experience that mimic the positive symptoms of schizophrenia. Some neuroleptic drugs like phenothiazines used for the treatment of both amphetamine psychosis and schizophrenia block the transmission of dopamine by preventing its uptake at the postsynaptic receptor site. Dopamine hypothesis does not provide complete explanation. Schizophrenia is a disorder with widespread symptoms. It is unlikely that a single neurotransmitter could account for all of them. Glutamate may also play a role in schizophrenia. Glutamate is an excitatory neurotransmitter that is widespread in the brain. In schizophrenia, low level of glutamate has been reported in affected persons. Neurological anomaly. Some studies suggest that negative, disorganized and some positive symptoms may result from damage to the neural system. The most common findings of brain scans include enlarged cerebral ventricles and decreased cortical volume, especially in the temporal and frontal lobe. Neurological deficits occur due to many reasons like excessive dopamine, viral infection, pregnancy and delivery complications, and maternal stress. Continued excessive dopamine activity leads to degeneration of the neurons in dopamine system, leading to exceptionally low level of dopamine activity and hence negative symptoms. Viral infections may lead to schizophrenia. Young children who had viral infections were 5 times more likely to develop schizophrenia than those who did not. Pregnancy and delivery complications may also cause brain damage that increases the risk for schizophrenia. A meta-analysis showed that schizophrenic children were passed through complications like low birth weight, prematurity, lack of oxygen, etc. during pregnancy. Substance abuse. One biological trigger may also be implicated. Stimulants can cause transient psychotic experiences and precipitate relapse of an existing psychotic condition. Research suggests that cannabis consumption can also increase risk of schizophrenia. The cannabis raises levels of cerebral dopamine and dopamine might precipitate psychosis. The cannabis raises levels of cerebral dopamine and dopamine may precipitate psychosis. Psychosocial perspectives. Under psychosocial perspectives, we have various explanations. First, we have psychodynamic explanation. Freud and other psychoanalytical theorists viewed schizophrenia as a retreat from unbearable stress and conflict. For Freud, schizophrenia represented an example of regression defense mechanism, in which a person follows an infantile and childhood patterns of behavior to feel secure and avoid the reality. The Freud's regression explanation has not received direct research support. Other psychodynamic theorists focus on the interpersonal withdrawal that is an important characteristic of schizophrenia. They view the disorder as a retreat from an interpersonal world that has become too stressful to deal with. Role of life stressors as a causal factor is generally accepted. Behavioristic perspective. Behaviorists emphasize the role of learning in acquisition of maladaptive behavior, which causes psychopathology. Behaviorists do not try to account for the onset of schizophrenia, but focus on how the behavioral symptoms of the different types of schizophrenia might be shaped through the process of reinforcement and extinction. Modeling may also play a part in the behavioral explanation of schizophrenia, as patients in hospital may see the bizarre behavior of other patients, get rewarded with attention, and later initiate similar behavior. Some influential theories attribute schizophrenia to process of modeling or instrumental conditioning. This does not explain how people who have never been exposed to other schizophrenic patients develop their behavior. Cognitive perspective. Cognitive theorists see the irrational beliefs of schizophrenia as a severe form of illogical thinking. Cognitive theorists believe that the people affected with schizophrenia have attention-related defects in filtering out irrelevant stimuli. It creates overwhelming situation. The stimulus overload produces distractibility, thought disorganization, and the sense of being overwhelmed by disconnected thoughts and ideas. As one patient of schizophrenia reported, everything seems to come pouring in at once. I can't seem to keep anything out. Socioeconomic status. Prevalence rate of schizophrenia is profound in low socioeconomic status. Stresses related with socioeconomic status may cause or contribute to the development of schizophrenia, but it is tough to establish causality. Individuals in lowest socioeconomic groups were 3 times more likely to be assigned a diagnosis of schizophrenia than those in the high socioeconomic group. Findings suggest that low socioeconomic status may trigger onset of schizophrenia in vulnerable individuals. In a study, 24% of episodes of schizophrenia seem to be precipitated by some acute life stress. Life experiences and family interaction. In case of schizophrenia, family can be a source of origin of the disease. Schizophrenia tends to run in the families. People diagnosed as schizophrenics are likely to have at least one parent with the same diagnosis. Highly emotional family environments might be stressful to patients. It has been observed that the patients from hospital who returned home to live with the parents or with a spouse were at high risk of relapse than patients who left the hospital to live alone or with siblings. It indicates stimulating role of the family in occurrence of schizophrenia. Expressed emotions is a measure of the family environment that is based on how family members speak about the patients during the private interview with the researcher. Some researchers focus on communication patterns in the family. Schizophrenia results from constant double-bind communication from one family member to the other, typically from one parent to child. In some cases, the verbal content of the communication may conflict with the physical or emotional content. For example, a young man whose mother visited him in his mental hospital was delighted to see her. He put his arms around her, at which point she stiffened. In response, he withdrew his arms, but then she asked, "Don't you love me anymore?" Confused and embarrassed, he blushed and his mother said, "Dear, you must not be so easily embarrassed and afraid so easily." Some evidence does indicate that people diagnosed as schizophrenic often grow up in families where communication is disordered and where at least one parent is critical and overwhelming. Urban living. It seems that living in an urban setting may increase the vulnerability of schizophrenia. Some studies showed association between urban living and schizophrenia. In a study, it was found that children who spent the first 15 years of their lives living in an urban environment were 2.75 times more likely to develop schizophrenia in adulthood than who spent their childhoods in rural settings. It indicates toward a possible role of the environment or nurture in schizophrenia. The social causation hypothesis attributes the higher prevalence of schizophrenia to the higher levels of stress that low-income people experience, particularly within urban environments. Treatment modalities that are available of schizophrenia include number 1, biological treatments, where we have pharmacological treatment. Most people diagnosed with schizophrenia receive some form of medication. Chlorpromazine, haloperidol, and clozapine are 3 of the most commonly used drugs. Chlorpromazine and haloperidol seem to affect only the positive symptoms of schizophrenia, whereas clozapine is more successful at treating the negative symptoms and is often effective when other treatments fail. Antipsychotic drugs have been so successful in treatment of schizophrenia that stay in hospital has declined to less than 13 days than formerly longer time of stay. It works as protective factor against relapse of disorder. Electroconvulsive therapy. ECT has been used as a major procedure in treatment of schizophrenia in the past, but it is less effective than antipsychotic drugs and useful for short-term improvement. Due to less effective mode, it has been curtailed with an increased emphasis on medication and psychosocial treatments. Psychotherapy. In psychotherapy, first we have psychoanalytical therapy. One of the first psychological treatment of schizophrenia was developed by Harry Sachs Sullivan in the early part of 20th century. He considered that schizophrenia arises from the personal and social problems. His treatment involved examination of life history of the individual, historical roots and current ramification of their maladaptive marked ambivalence interpersonal relationships. Resolution to this conflict through the psychotherapeutic process was thought to result in improvements in psychosis and maturation of the patient. Sullivan's approach of treatment has encouraged the use of psychological treatment of schizophrenia, but it has been found least effective and is no longer in use. Family interventions. Family therapy has been found effective in minimizing the strength of symptoms of schizophrenia. Family therapy reduces high level of expressed emotion. On the basis of related studies carried out in this field, it was concluded that family interventions reduce risk of relapse by about half in comparison to medical care only. It has also been noted that family interventions decreased the frequency of admissions to hospital, time spent in hospital, and improved compliance with the medical regimes. Social skill training. Patients suffering from schizophrenia show gross deficit in their interpersonal skills. They fail to recognize basic emotions such as happiness and anger. Social skills training makes them able to function better. Social skills include employment skills, relationship skills, self-care skills, and skills in managing medication or symptoms. Patients learn these skills, get corrective feedback, practice their new skills using role-playing, and then use what they have learned in the natural settings. The results of social skills treatment are mixed. Some studies showed improvement in specific skills that make them function better. Other research studies have failed to find any significant improvements in the patient's social functioning. Problems lie because skills are domain specific, whereas social functioning requires a broad range of skills. Cognitive behavior therapy. CBT has been found effective in the treatment of schizophrenia. It was found that patients who received CBT showed decrease in their hallucinations and delusions compared to patients who received either supportive counseling or routine care. Two forms of CBT are used in therapy of schizophrenia: stress management and belief modification. The goal of CBT is to decrease the intensity of positive symptoms, reduce relapse, and decrease social disability. Stress management involves working with the individuals to help them cope with the stress associated with psychotic experiences. One study found that stress management intervention evidenced a greater improvement than other type of interventions. Belief modification involves attempts to change the nature of delusional beliefs the individual may hold. In this strategy, two cognitive interventions are used: verbal challenge and behavioral hypothesis testing to counter delusional beliefs and hallucinations. The patient is not told that the belief is wrong, but is asked to consider an alternative view provided by the therapist. New possibilities may then be tested in the real world as appropriate. Reflecting the novelty of this approach, a meta-analysis was conducted by Jones et al. In 2000, which showed that belief modification as an intervention reduced both the frequency and impact of hallucinations, that is a prominent characteristic of schizophrenia. After going through this chapter, we have the summary on schizophrenia, wherein we understand that schizophrenia is one of the most severe kinds of psychopathology. DSM-4-TR presents a very comprehensive clinical picture of schizophrenia. Schizophrenia includes severe disturbances in thinking, speech, perception, emotion, and behavior. It involves loss of contact with reality, bizarre behavior, and distorted expressions. Symptoms of schizophrenia has been categorized into three clusters: disorganized type, positive type, and negative type. There are different subtypes of schizophrenia, which are disorganized, catatonic, paranoid, undifferentiated, and residual type. There is no exclusive cause of schizophrenia. Number of causes such as biological and psychological causes have been implicated in occurrence of schizophrenia. The most important neurotransmitter implicated in schizophrenia is dopamine. Treatment of schizophrenia is available, but no single treatment is effective. It can be treated effectively when antipsychotic medication is combined with psychological therapy.